Now we'll start with the fourth session for today. Immunization is a global health and developmental success story, saving millions of lives every year. It is the key component of primary healthcare and an indisputable human right. So the topic for next session is vaccination in family practice.
Chairpersons for this session are Dr. Venkatesh Sankarapandian, Dr. John Jacob, Dr. P Krishnamoorthi. Dr. Venkatesh Sankarapandian finished his MBBS from Tirunelveli Medical College and DNB Family Medicine from Christian Fellowship Hospital, Vatanchitram, and he is now Professor and HOD, Department of Family Medicine, CMC Vellore. Dr. John Jacob, he did his MBBS from TD Medical College, Alappuzha, Kerala, completed DNB Family Medicine in 2006, currently working as consultant in Christian Fellowship Hospital, Vatanchitram, Tindikal. Dr. P Krishnamoorthi did his MBBS from JIPMER, gold medalist, and MD from Madurai Medical College. Currently, he is the HOD, Department of General Medicine, MMHRC Madurai, and he has been working in this hospital for more than 30 years.
Dr. Safir, Dr. Uma, and Dr. Sheela. Dr. Safir Ashraf, he finished his MBBS in TD Medical College, Alappuzha. Did his DNB in Family Medicine from Meenakshi Mission Hospital and Research Center, Madurai. He is at present working as an assistant surgeon at PHC, Kannur. He has worked as a trainee in charge of Ardhram Mission by Government of Kerala, and he was in charge of COVID control activities in Alappuzha district. He has presented a lot of papers about a wide range of topics since 2012.
Over to the chairperson.
In continuing our CME on this family medicine program, another important topic. See, we discussed about the infection and how to treat with antibiotics. Now we go to the next step of prevention, how to prevent that infection. And one of the important way in the prevention is vaccination. We all know about pediatric and antenatal vaccination. Now this is another topic, adult vaccination. To tell about that, we have our Dr. Safir, who will enlighten us on this adult vaccination. You want to say anything, sir? Over to the speaker.
Good morning, respected teachers, seniors, and dear colleagues. In fact, for me, it's like back to the home ground after 5 years. I was the DNB resident of this institution from 2014 to 17. So I will be covering regarding some topics regarding vaccination in general practices, mainly in adults. My presentation will be mostly questions, no answers. So we'll go to the case scenario. Suppose Mr. X, who is a known case of PLHA. PLHA is people living with HIV/AIDS. His HbA1c and HCV status are negative. He is presenting to your OPD after 24 hours history of dog bite. On examination, he has minor scratches and abrasions without bleeding over the dorsum of his foot. So far, he has not received any rabies vaccine. How will you manage this case? Can anyone volunteer? Answers, please. Okay. So, WHO is aiming for 0 death by 2030 in case of rabies, because rabies, as you know, it's 100% fatal disease, but it is 100% vaccine preventable disease. So almost 99% of the cases of the rabies is due to the bite of the dogs, and less than 1 to 2% by the cats. So it's very alarming number, because every 15 minutes worldwide, 1 death is happening because of rabies, and 4 out of the death are in children. So our aim is to vaccinate our lives and vaccinate our canines, and to prevent the transmission of rabies. So World Rabies Day is observed on September 28th. So my topics are advertised from the National Rabies Control Program 2019. It's an updated version of the 2018 WHO protocol, but some of the things mentioned in WHO is not adopted in our national guidelines. So categorization of the wound, first we have to categorize the wound, category 1, 2, 3. Category 1, it's just touching or nibbling of the intact skin. Category 2 is nibbling of the uncovered skin. Category 3, it's the transdermal bite or the exposure to the mucosa. That means if your cat or dog accidentally licks your lips, it comes under category 3. So in case of category 1, there is nothing more required, just wash the wound, Category 2, wash the wound along with rabies vaccine, whereas in category 3, we have to administer rabies immunoglobulin also. Wild animals will be considered as category 3, irrespective of the bite. So in case of wild animals, you are supposed to give category immunoglobulin if the patient is not previously vaccinated. But in case of immunocompromised individuals with low CD4 levels, there is a twist. So how will we prevent rabies? It can be discussed under post-exposure, pre-exposure and post-exposure treatment of person who has been previously vaccinated. What's the first and foremost thing what you are supposed to do? Suppose in the middle of the night only this bite is happening. Should we take the patient to the nearest hospital, which will be somewhere 10-15 kilometers apart? What's a wash? For how many minutes? 5, 10, 15, 20? Yes, we have to wash the wound under running water and apply our normal soap for 15 minutes. Is there any need to apply turmeric, curcumin, water? Nothing like that. Okay, so we have to wash the wound for 15 minutes, followed by application of, if available, any povidone iodine or antiseptics. So should we delay the process of washing? Suppose the patient is presenting after 3 days or 2 days. He is I took the bath. Should we avoid washing of the wound? No. We should still suggest 15 minutes washing of the wound, because 80% of the reduction of the chances are there by simple washing for 15 minutes. So rabies vaccine is a cell-cultured embryonic vaccine. It's a lyophilized powder. We have to reconstitute the vaccine. Reconstituted vaccine has to be used within 6 to 8 hours. So it's stored at 2 to 8 degrees Celsius. So there are two routes, intradermal and intramuscular. So now we are going behind intradermal. Previously it was intramuscular. Intramuscular we need to apply a larger doses of the vaccine. Intradermal it's only 0.1 ml of the vaccine, because since in resource poor settings it will be very helpful. And the intradermal, the multiple sites, this antigen presenting cells will be taken the vaccines and it will be presented to our lymphocytes and there will be activation of the immunity. The study shows that the immune response of the intramuscular and intradermal are comparable, but still in immunocompromised individuals, intramuscular is preferred over intradermal. So the site of the intradermal is our deltoid or the suprascapular areas. In less than 2 years kids, it's the anterolateral thigh. Rabies vaccine should not be administered in the gluteal region. We have mentioned the dose of the intradermal is 0.1 ml. So 0.1 ml either 2 site, but the dose of intramuscular, it's not 0.5 or 0.1, it's not 0.5 or 1 ml. It depends on the vaccine manufacturer. They will be providing the diluent with the vaccine. If after reconstitution, if it is 0.5 ml, that is a dose for that patient. If with another brand comes with 1 ml diluent, that will be the 1 ml will be the dose for the IM dose for the patient. So PEP recommendations in category 2 who has not previously taken vaccination. It's 2 site 0.1 ml, 0, 3, 7 and 28. It's known as updated thigh regimen. Intramuscular is 0, 7 and 14 and 28. 5 doses are there. But WHO 2018 has come with another guideline where they have omitted the 28th dose, but we are not following this thing in our country. We are supposed to follow the 2019 NRCP guidelines. That's 2 site 0.1 ml, 0, 3, 7 and 28, intradermal or intramuscular 0, 3, 7, 14 and 28. I hope this is clear. So category 3 is the same, but we have to administer immunoglobulin in a previously unimmunized individual. If suppose the patient has taken IDRV or the intramuscular vaccine, prior to that there is no need for immunoglobulin irrespective of the wound. So previously immunized, what we are supposed to do is, suppose if the patient is presenting to your OPD saying the history that in the past I had taken intradermal or intramuscular full course rabies vaccine was taken. So should you give the complete dosage? Yes or no? No. Only on day 0 and day 3 at single site, either intramuscular or intradermal. But if the patient is presenting within the 3 months history of, prior to 3 months that he has taken the complete dose of vaccine, means there is no need for giving PEP, just wash the wound. Rabies immunoglobulin is not even indicated in category 3. So suppose if the patient misses a dose of rabies vaccine in between, what should we do? Should we restart or resume? Yes, previously it was to restart, but now it's to resume, provided within the first 10 days we have to administer the 0, 3 and 7 dose. 0, 3 and 7 are the primary doses and 28 is the booster dose. So if you are sure that we can administer that 3 doses within the first 10 days, then only you have to resume the IDRV or IMRV. Otherwise, you have to restart. Again, pre-exposure prophylaxis. It's again 0.1 ml, 0.7, either 21 or 28 days. It's a NRCP guidelines, but WHO comes with only 2 doses that we are not following. In category 3, we are supposed to give either equine rabies immunoglobulin or human rabies immunoglobulin to provide the passive immunity. Equine comes with at the dose of 40 international units per kilogram. HRIG will be at 20 international units per kilogram. Cost will be, ERIG will be costing around 5,000 for the patient, whereas HRIG will be costing around 25,000 to 30,000 for the patient. So infiltrate the maximum immunoglobulin in and around the wound, not to the distant muscle. That's an update in the 2019 guideline. Who is she? She is Jana Gissi. Anyone knows what's Milwaukee protocol? She is supposed to be the first human to survive rabies in whom a vaccine was not administered, it seems. There was one protocol with continuous sedation for 2 months with our anesthetic agents and all. So this will happen only in 0.001 cases. Otherwise, it will be very fatal. So what's the latest armament? There is a monoclonal antibody for the use of, instead of rabies immunoglobulin. It's known as rabies shield. It's there in the market. Dose is 3.33 units. Its dose is very less compared to the HRIG. HRIG will be costing around 25,000 for an 80 kg adult, whereas this one will be costing around 5,000 rupees. So just a brief of our category 1, 2, 3 and what to do. Next one is vaccine, tetanus. Should we give TT injection every 6 months? What's the validity of TT injection? Yes. After the complete course of tetanus immunization, we can wait for 5 years. Because what's the complete course of immunization means? 3 doses of tetanus injection given apart in 1 year. 0 dose after 1 to 2 months, then after 1 year another booster. So if the patient has received that 3 doses means he is protected against small wounds for the next 5 years. So if the wound, any wound first should receive surgical toilet. If the wound is clean, clear with less tissue damage and the other wounds, we can categorize into 4 parts, A, B, C, D. A means full course of TT or a booster within 5 years. Nothing is required in either of the two. If the booster is between 5 and 10 years means we have to take 1 toxoid dose. If the booster is more than 10 years means in clean wound only 1 toxoid dose, whereas in unclean wounds means we have to give passive immunization using human tetanus immunoglobulin also. In category 3, that D means status is unknown or not vaccinated means complete tetanus course, and in ugly wound means we have to give TT along with immunoglobulin. So these are the regular vaccines used in adult: TDAP, MMR, varicella, human papilloma, hepatitis A, typhoid, pneumococcal, etc. So I will just briefly go upon the vaccines. Is this slide clear? No. Okay. So it's a CDC recommendations. For adult, every year we are supposed to give, we are supposed to take seasonal influenza vaccine. Seasonal influenza vaccine, it's 2 types, live and live is there and attenuated is there, inactivated is there. So live vaccines, its dose is nasally we have to apply, but it is contraindicated in the immunocompromised. Inactivated vaccines we are supposed to give IM. Every year the antigen drift will be happening, so the manufacturers will be coming with new strains of vaccine. Tetanus we already discussed. Then comes MMR. MMR is also advocated for adults up to 64 years of age, 2 doses. Then comes varicella. Varicella is not a part of our routine in government protocol, but in private they used to take. After 12 to 15 months, we have to take the first dose, and then from 4 to 6 years, we have to take the second dose. Then human papilloma virus. Human papilloma, what's the brand name of the vaccine used? Gardasil is the global brand. Our Serum Institute is coming with one vaccine named Cervaris, it seems. So it's in trials are going on. That will be the cheapest vaccine to be available in the market. Only 200 rupees is the expected price. Gardasil will cost around 4,000 rupees. So can we give HPV vaccine to males? It's only females, only males, or both? Only? HPV will prevent the anogenital penile cancer also. So we are supposed to give it to the both males and females. So HPV dose is 3 doses. It's recommended from till the age of 26, but after shared discussion with the patient, we can extend up to the age of 45 years, not beyond that. Gardasil is right now the brand available. Then comes the pneumococcal. Pneumococcal, what's available in India is PCV13, but CDC recommends either PCV15 or PCV20. If you are giving PCV20 means only single dose is required. If PCV15 means that should be followed by a polysaccharide vaccine, PPSV23. But in India, unfortunately, I think we are having only PCV13. So we should give one PCV13 followed by PPSV23 after a year. So pneumococcal vaccine should be given regularly for all adults who are more than 65 years. Less than 65 means any comorbidities, chronic lung conditions or heart, whatever it may be, immunocompromised state, we are supposed to give. Then comes the meningococcal and A type and serotype B, then Haemophilus influenza. These are the routes of the vaccines. I will skip through this. So, what's the post-exposure prophylaxis against varicella? I think it will be an exam question for you. So, suppose the patient is presenting to your OPD after 2 days of history of close contact with varicella patient. What should you do? Anyone? We have got, in fact, 4 options are there. Varicella vaccine we can give subcutaneous route, varicella immunoglobulin intramuscular route, but varicella immunoglobulin is very rarely available in the normal towns. So in that case we can give IVIG. The last but the least preferred is giving acyclovir or our valcyclovir after 7 to 10 days of exposure. So varicella vaccine is given through subcutaneous route. All individuals above 12 months we can give, but the patient should not be pregnant or not immunocompromised, no allergic history. It should be administered within 5 days of exposure. Whereas varicella immunoglobulin, it's meant for the immunocompromised or the pregnant ladies. It's based on the weight of the patient. It should be given within 10 days. So varicella vaccine within 5 days, varicella immunoglobulin within 10 days. In the absence of varicella immunoglobulin, we can give IVIG. IVIG, the recommended dose is 400 milligram per kilogram. So this is the adult vaccinations in splenectomy individuals. So those who have undergone splenectomy, high chances are there they can get the infection with the encapsulated organisms. So every splenectomized individual should get pneumococcal vaccine, influenza vaccine, meningococcal type A and type B, and seasonal influenza. So if you are planning for an emergency splenectomy, means after splenectomy, after how many days you have to initiate this vaccination? After 14 days you have to initiate. If it's a planned surgery, means prior to 14 days we have to complete all these immunizations. So then comes the COVID era. So I think Jacob sir is also an alumni of our prestigious institution, TDMC Medical College. Here we had the second case of the COVID infection. In fact, he was the primary contact of the first case. She was from Thrissur. This boy was from Alappuzha. So it happened around 2020 February. Unfortunately, I was also caught behind this, was put under quarantine for 28 days, 14 days in hospital and 14 days at home with 2 RT-PCR negative results. It was one of the most dreaded experience. So 2 types of vaccines are there, whole virus vaccine and virus complement vaccines are there. So the highlighted vaccines are available in India. Covaxin, then the mRNA vaccine, Pfizer and Moderna, AstraZeneca or the Covishield. It's the replication incombinated vector vaccine. Then the Corbevax and Covax. What's the youngest age from which we can give COVID vaccine? Not in India, in US. 6 months. Next update may be from birth onwards. So from India, it's from 12 years onwards. We had got 2 choices, Covovax and Corbevax. Covovax in private sector, Corbevax in government sector, and above 15 years, Covaxin. Then we are also got the Covishield. So this is the contraindications to vaccine administration. Pregnant women, avoid all live vaccines due to the potential risk of the fetus. Can you say one exception for this? Pregnant women can receive yellow fever vaccine if that is their emergency. What's the validity of yellow fever vaccine? 10 years? It was 10 years, now it's lifelong. So the valid immunity starts from 10 days after the administration of the vaccine till lifelong. So we should avoid these vaccines, red ones in immunocompromised individuals, BCG, oral polio, yellow fever, typhoid oral, and varicella. Green ones can be given. So what's the answer for this question? First and foremost, we had to wash the wound for 15 minutes with soap and water. Second, he is an immunocompromised individual. So we have to give him category 3, even though the wound comes under category 2. That is minor scratches and abrasions without bleeding. It's actually category 2, but since he is immunocompromised, we are supposed to treat him as category 3. So we have to give him immunoglobulin and TT as per that schedule. So in immunocompromised individual, IMRV is preferred over IDRV. RIG is indicated even if the wound is of category 2. Okay. Unfortunately, our sister who was administering the vaccine got a needle prick. So what you will do in case of the patient is HIV positive, so what prophylaxis you are supposed to give? So this is a classification of the retroviral drugs. NRTA, nucleoside reverse transcriptase inhibitor, tenofovir, lamivudine, NNRTA, efavirenz, protease inhibitor, ritonavir, then integrase inhibitor, dolutegravir and raltegravir. Now our regimens are containing this dolutegravir. So the NACO has come with latest guidelines. In 2021, they have changed the PEP regimen. In adults over 10 years of age and 30 kg, more than 30 kg, the preferred regimen is TLD. It comes under as a fixed dose combination drug like our RNDCP drug. So we have to give within 2 hours and not beyond 72 hours. The regimen duration is 28 days irrespective of the regimen. So in case if TLD is not available, tenofovir, lamivudine, dolutegravir is not available, then we can give tenofovir, lamivudine, ritonavir, booster, lopinavir. If that is also not available, means our TLE, tenofovir, lamivudine and efavirenz. Then only 2 more slides. Hepatitis B exposure. How will you manage? Hepatitis B, there is idea is responder and non-responder is there. After vaccination of the complete status, 0, 1 and 6 months, if the anti-HBs titer is more than 10 milli international units per ml, then he is a responder. Lifelong, he doesn't require any more prophylaxis. But if it is less than 10 means he is a non-responder. So if he is a documented responder after complete series means, even if the source patient is HBsAg positive, there is no action is required. If the patient, suppose the healthcare professional or the person is a documented non-responder after 2 complete series of vaccine, 2 times he has taken 016 hepatitis B, then he comes under, if he is getting exposure to a source positive case means, then he has to be given 2 doses of hepatitis B immunoglobulin taken 1 month apart. One dose of hepatitis B immunoglobulin will be costing around 50,000 to 60,000 rupees for an adult. For a baby itself, it will be 5,000 rupees. So if the response is unknown, means again you have to check the anti-HBS. Everything will be depending upon our anti-HBS titer. So if anti-HBS is more than 10 means nothing required. If it is less than means, if he is even after 2 doses of complete vaccination, 2 times of complete vaccination means again he has to be given immunoglobulin, otherwise single dose of immunoglobulin. Same with HCV. HCV exposure also, after 48 hours we are supposed to check the HCV RNA and HCV antibody titer. So if the HCV RNA is negative means we will be going behind the antibody. The testing will be around 4 weeks, around 12 to 16 weeks, then from 6 weeks. So hopefully I think you got at least some points from this. Thank you.
Well, that was an excellent lecture, Safir.
Thank you, sir.
It was a very good presentation, covered most of the vaccines. I think one point we have to remember as family physicians, if we are recommending hepatitis A or cholera vaccines, those waterborne diseases, we should also tell them to boil water, otherwise they are going to get exposure.
So travel vaccine will be next topic. So
Okay, yeah, we'll talk about that. The pneumococcal vaccine, I think it's currently available in India and government is giving for children.
Pneumococcal it's available, but only PCV 30. So
23 is not available. Huh?
PPSV 23 is there, sir.
Yeah, it's available.
PCV 13, PCV 15 and PCV 20 are the conjugate vaccines. PPSV 23 is the pneumosaccharide vaccine. So what it is advocated is, if a patient is receiving vaccine means only one PCV 20 is enough. If he is getting PCV 15 means after an year he has to be given PPSV 23. But in India it's only PCV 13. Then after 1 year we have to give PPSV 23 in case of adult. But in children's, I think 6 months, government is giving at 6 months, 6 weeks, 14 weeks and 9 completed weeks. 3 doses, PCV 13 they are giving free of cost.
So for those who are more than 65 years, if they don't have comorbidity, I think Pneumovax 23 can be safely administered.
Good.
Only those with comorbidity, these 2 doses of...
No sir, PCV 20 means only single dose, but PCV 20 is not available in India. We are having only PCV 13 or PCV 15. Even if it is 13 or 15, we are after an year we are supposed to give PPSV 23.
Thank you.
Thank you, Dr. Safir. 2 points. Like one thing I was stating is that as family physicians, we need to be updated about all the available adult vaccines, because we'll be the first contact of with the patient, and most of the people come to us. So it will be good for us to know what are the vaccines available and keep updated. That's what we are doing right now. I thank the organizations for adding this topic into the group. And one more thing about the COVID vaccine. I was looking up an article. It says that primary care physicians are the best placed to address COVID hesitancy, vaccine hesitancy. I was thinking about the personal experience in our own place. Initially there was COVID hesitancy all over the world, India, even in our place. And it was so good to see that when our health workers went and told the people, they began to come forward. And those who could not come, they could do home visits and give the vaccine. So primary care plays an important role in vaccinations. So being aware of the vaccines, what is available, what is essential, and being able to take it to the doorstep of the people at need, that is a role that we are greatly placed to play. Thank you very much.
Just before conclusion, with the rise in diphtheria in young adults, there was some recommendation about Tdap, I think.
Tdap is there, sir. Now,
tell the audience, one dose of
TDAP
Tdap, then you continue with TT every 10 years. Thank you.
I think as family physicians, we need to realize that we need to know the best, but we also need to be able to change when and adapt when situations and individual factors matter. In rabies, significant numbers of people don't come back for the second and third doses, and we need to cover them. When we open a vial, most of us are going to waste the rest of it because we don't get 2 or 3 dog bites in a day in most health centers. So what we do is we give 0.2 ml intradermally in 4 different sites on the first day itself. And there's strong evidence that if the person doesn't come back for the second and third dose, they will still get the optimum coverage that they need. So remember to use evidence and the knowledge. We need to know the best, but you also need to work around it when patients don't follow the guidelines. They also matter. And this regime has got evidence to support it. If they come back, carry on with the second and third doses. Regarding HPV, 2 doses have been found to provide adequate protection in studies, but the drug companies are not keen to publish those results. And one of the effects of those studies was that many women dropped out after even the first dose of HPV vaccine. And they are also shown to have almost equally good protection. But the drug companies will not publish it. So always look at the evidence in a careful way as family physicians.
Thank you, sir. I would like to inform that there are till 2 more speakers for this session. The next speaker for this session is Dr. Uma. She is a senior consultant and developmental pediatrician in the Department of Pediatrics, Madurai, Meenakshi Mission Hospital and Research Center. She finished her MBBS at 1989 in Tirunelveli Medical College and her DCH from CMC Vellore in 1997. She completed her DNB in Meenakshi Mission Hospital, Madurai at 2009. She completed her PG Diploma in Developmental Neurology, Trivandrum Child Developmental Center. She has got 25 years of pediatric experience, 15 years of developmental pediatric experience, and 10 years of teaching experience. Over to you, ma'am.
Now we are moving from adult to pediatric vaccination. So I have given the heading as Indradhanush. I will explain within 3 slides. This is my journey, as they have told, with Tirunelveli Medical College, CMC Vellore, and University Kerala Child Developmental Center, and Meenakshi Mission Hospital. So today our learning will be about National Immunization Schedule, IAP Immunization Schedule, little bit about Mission Indradhanush, recent changes in IAP, and common questions that will arise in everyday life in pediatric, and newer vaccines. So this is a National Immunization Schedule. So here at the birth we will give BCG, hepatitis B, and 0 polio. There is a maximum age. This is BCG up to 1 year, and hepatitis B within 1 day, and 0 polio within 15 days. And at 6, 10, 14 weeks, we will be giving oral polio in National Immunization Schedule, pentavalent, that is DPT, hepatitis B, and Hib vaccine, rotavirus. These 3 in 6, 10, 14 weeks. Along with that, we will be giving fractional IPV, that is inactivated polio, which we will give in National Immunization Schedule, the intradermal dose, that is a 0.1 ml. Pneumococcal conjugate vaccine in National Immunization, we will give 6, 14 weeks with 9 months completed booster dose. Measles, rubella, 9 months completed, booster at 6 to 24 months. JE vaccine in high endemic areas, first at 9 months and 16 to 18 months second dose. Along with that, even though it is not a vaccine, they will include vitamin A in a National Immunization Schedule. And this is about Mission Indradhanush. So it is an initiative by Indian government to fully immunize all children against 7 vaccine preventable diseases. Why they have made? See, even now in India, many districts, nearly 50% all unvaccinated or partially vaccinated children. So to cover this area and increase the vaccine percentage, they included this Mission Indradhanush. In that, what will they do? Every month in phased manner, they will go to these districts and they will cover these children and pregnant women. Children especially less than 2 years. So initially they made it as Mission Indradhanush, that is to achieve 2020. These were children and pregnant women. Later they changed to Intensified Mission Indradhanush because they preponed this 2022 to 2018 to achieve this coverage. and they are planning to give this much crore and lakhs of pregnant women, children and pregnant women. So these should be closely monitored also. So with this, what happened? So with this Mission Indradhanush and intensified Mission Dhanush in the phased manner, so this under 5 mortality has decreased from 45 to 36 over 4 years. And with this coverage, see in 2022, with the target of 90%, this survey showed they have reached 77.6%. So then move on to IAP vaccines. Along with National Immunization Schedule, we are added these vaccines: influenza, typhoid conjugate, hepatitis E, A, varicella, Tdap, and meningococcal and human papilloma virus. So this is the schedule. So yellow color is the recommended age, and green color was the catch-up range, and this is for special situation. So why these two schedules are available? So National Immunization Schedule, this government has made, targets whole population with maximum benefit with reasonable expenditure with limited visits. IAP, they have made maximum benefit that is ideally to be given to the children with no economical constraint. So this is recent guidelines about flu vaccine by IAP. See, previously less than 3 years we are giving only 0.25 ml. We will tell this is a pediatric dose. After that and all, only adult dose 0.5 ml we will be in intramuscular dose. Now they have changed and they have noted with the studies that we can give 0.5 ml with safety, with whole safety, and immunogenicity is also there. Next one is typhoid vaccine. What they have told us, VA conjugate vaccine we can give only 1 dose. They have proved with the studies. We are having 4 types of vaccine. These 2 we are not now using now. We are using these 2, that is one polysaccharide, another one is a conjugate vaccine. So little bit about polysaccharide and polysaccharide conjugate vaccine. What is the difference? See, polysaccharide we are having with pneumococcal, meningococcal and typhoid. See, when polysaccharide vaccine when we give, that is P23 like that, so it will only stimulate the B cells and it won't produce the no memory cells. But when we conjugate with some protein, it will stimulate both T cells and B cells. These T cells make the B cells to produce the memory cells, which is necessary when we give the booster dose or when we expose to the antigen. So this when we stimulate the T cell, it will produce an increase in the antibody titer persistently. As I have told, this IAP told it is a single dose. Typhoid vaccine is enough. Conjugate vaccine is enough. So few frequently asked questions within us in our day-to-day life. We will be having more questions. I am covering little bit about BCG. Why this has to be given at birth? BCG stimulates cell-mediated immunity that is not transferred from the mother. Maternal antibody don't inhibit which we are giving. Why this to be given up to 1 year? Because most occur natural clinical or subclinical infection by 1 year of age. So they see this picture, this is a second scenario. 6 months old came with accidental detection of swelling in the left axilla. This most probable diagnosis we will tell one is BCG adenitis or a infective etiology. So what is the treatment if it is a BCG adenitis? So wait and watch. If it is a BCG adenitis, no role for antibiotics or antituberculous drug. If it is too fluctuant, we can aspirate with the needle. If it is too big only, we will go for a excision, which is a rare. So next scenario, the same child presents with more swelling like that and sinus formation. What are the examination we will do and what history we will get? There is examination is lymph node enlargement is there, any other lymph node, and hepatosplenomegaly, there is failure to thrive is there. There is a history of consanguinity is there. Why we have to think about all these things? For a disseminated BCG-nosis. Where will it occur? It is a severe combined immunodeficiency, HIV, and Mendelian susceptible mycobacterial diseases and chronic granulomatous diseases. So this is one slide which shows that this Mendelian susceptible is involving this interleukin 12-23 with gamma interferon loop, which will be defective here, which is an autosomal recessive condition. Those are unable to control these organisms. So next slide, with 6 months old Banu, he came without BCG scar. We can see this without BCG scar after 6 months. Which time we will give for it to happen. So if there is no scar, what will we do? Is the child is not protected, whether we have to give the manto and see whether reactive or not, or any day to revaccinate. So BCG scar means what? So BCG scar, if it is not there, you are protected. If it is not there means you are protected against infection. Absence means does not mean you are not protected. Not like that. It is an evidence, only evidence that you have received the vaccination. If there is no scar, even with the absence of scar, seroconversion can occur. So there is no evidence of benefit with repeat vaccination. So when will you go in repeat vaccination? Any doubt about receipt of vaccine, it may be repeated. So now about polio, why we are giving both OPV and IPV in India still? So OPV, it has a better pharyngeal and gut mucosal immunity, but there is a risk of vaccine-derived paralytic polio and associated paralytic polio. So VDPV occurs when the population immunity is low. So WHO says, when shall we shift to IPV only? That is, when you achieve the immunization coverage of 90 to 95%. So for that only government has announced Mission Indradhanush and Intensified Indradhanush, everything. So these are the polio vaccine by IAP and national immunization. So everywhere we will give zero polio first, but in IAP we will give only injection polio 6, 10, 14 and booster at 1.5 years and 5 years. 5 years they have added recently, and in national immunization they will be giving OPV at birth, 6, 10, 14 weeks again OPV, and only fractional IPV, that is 1/5 dose of the IPV, 0.1 ml also intradermal. But both are immunogenic. Even though we are giving small amount intradermally, when we give intradermally, the dermal dendritic cells will do better work like a intramuscular dose. Why we have to still give zero polio? Zero polio, it is acting as a priming dose. When you give zero polio, this 3 viral percentage, seroconversion percentage, which is better when controlled to the control group. And when you give zero polio, as we are having maternal antibodies, there is a less chance of VAPP. It is vaccine associated paralytic polio, which will occur in the first dose. And priming with OPV induces better mucosal immunity with IPV. So next we are moving to hepatitis B vaccines. So the baby with birth weight of 1.5 kg, mother is HBs antigen positive. So what will be our schedule? If more than 2 kg, well, because when you give hepatitis B vaccine, the immunogenicity will be good. So at birth, if more than 2 kg, we will give immunoglobulin and vaccine within 12 hours of life. So 2 more doses with 1 month and 6 months. But when it is less than 2 kg, at birth we will give both, even though it is less immunogenic as mother is HBs antigen positive, but we have to give 3 more doses. So which HBV schedule is effective? Because we are having so many schedules like 0, 1, 6 and 0, 1, 14, 6, 10, 14 weeks. So many schedules are there. So studies shows that so antibody titer level is very good with 0, 1, 6. And how will you follow up the baby born like this? With HBs positive mother, we had given immunoglobulin and also vaccination within 12 hours of life. Do HBs antigen and anti-HBs antibody levels at 6 months. If level is less than 10 milli-international units per milliliter, there are non-responders. So at that time, you will be giving repeat 3 doses and check after 1 month. So another scenario, so one child came here. So 1 month back, I had recurrent seizures and they will put on carbamazepine. So now they are coming with DPT vaccination. So will you give or not? So for that we should know what is the absolute contraindications for DPT and precautions. That now I are telling it is a precautions. So absolute contraindication is only 2, only anaphylaxis. Another one is encephalopathy within 7 days of giving vaccine. That is in the form of coma, altered sensorium and prolonged seizures. Precautions, the conditions like moderate to severe illness, GBS occurring within 6 weeks of the previous dose, uncontrolled seizures and progressive encephalopathy or neurological disorder until treatment regimen has been established and condition stabilized. These are precautions. So when it is there, we have to one-to-one discussion with the parents and overweigh the benefit, then give the vaccine. So about TDAP, recently IAP have advised 1 dose in adolescents and adult. Even though it is an adolescent adult, why I am talking in pediatric, it has a cocooning strategy, we will tell. It is a effect. Why to give one is immunity wanes after, that is mainly pertussis, immunity wanes after 6 to 12 years. Now here adolescent we are giving aimed at reducing the incidence in this group, and 80% of the cases of pertussis in infants, that is infant pertussis 80%, are occurred from the adult contacts, even though adult will have a mild disease, but in infants 87 to 100% deaths due to pertussis, it's less than 6 months. So when you give this adolescents and adult in this age, it will has a cocooning strategy. So about PCV, so this is a primary series dose, booster dose, in the months and years I had given. So when the age advances, the dose will be decreasing. Why it is? So as age advances, the baby's immune system matures and they need only little amount of antigen to produce the immunogenicity. So about pneumococcal, one scenario, 3-year-old presenting with nephrotic syndrome, not given pneumococcal, what will be our advice? So 2 doses of pneumococcal conjugate, PCV 10 or 13, 8 weeks apart. Then we will go towards 8 weeks after completion of pneumococcal conjugate. This PPV 23 we will be giving. So it should be started at the time of initial diagnosis before child becomes severely immunosuppressed. So now we move on to preterm. So everybody will have a doubt that the preterm immune maturity will be less, whether to give according to the chronological age or the gestational age or the weight. So even though they will have immunological immaturity, if we give, they will respond very well. So we have to vaccinate according to the chronological age, not the post-conceptional age or the weight, because they have very increased risk for vaccine preventable diseases. So another scenario, see 5-year-old Puvalagi nephrotic syndrome child getting prednisolone 35 mg. They came for the MMR vaccine, that is live viral vaccine. So here there is a steroid with dose, how much dose we are giving, how many days we are giving, and which vaccine, live viral vaccine we are giving. So corticosteroid and vaccine, what is the schedule? So if more than 10 kg, we are getting only 2 mg per kg per day or less than 20 mg per day, we can give vaccine during the treatment itself. So if it is more than 10 kg, more than 20 mg per day or more than 2 mg per kg per day if the child is getting, but giving only for less than 14 days where immunosuppression is less, we will stop steroid and we can give the vaccine. Next one is, if the same scenario, the second, if they are giving for more than 14 days, there's a immunosuppression will be there. So we have to discontinue steroid. After 1 month only we can give the vaccination. So where will we give vaccine in the pediatric? This is anterolateral aspect of the thigh where vastus lateralis only is present. So between the junction of the upper and the mid third. This is the place we will give. In older children we can prefer the deltoid muscle also. Another scenario, Sarvesh, so he had received 3rd primary series of Pentavac with a gap of only 23 days instead of 28 days. So for that we should know some general instructions, that is minimum interval should be between 2 inactivated vaccine is 4 weeks except rabies. When we will give 2 live viral vaccines, if not administered on the same day, they should be given at least 4 weeks apart except live oral vaccines. And vaccine administered up to 4 days before minimum interval. That is, instead of 28 days, if we give 24 days, then it is counted as valid. If it is 5 or more days, it is counted as invalid and the dose should be repeated. And there are 2 slides about newer vaccines on trial, that is BCG. So on phase 3 trial, 3 vaccines are available, VPM 1002 and MIP and Mycobacterium vaccae. So in India also, this phase 3 trials are going on. So this is preventive as well as immunotherapeutic role is also there for these two. Immunotherapeutic is, so when the child is on ATT or adult is on ATT, so when we give this will stimulate the macrophages and our immune system in such a way that the sputum will become negative very early. Next one is dengue vaccine, that is Dengvaxia.
Time, madam, time please.
Yeah. This is the last one. So Dengvaxia, so the recommendation is 4 serotypes for 4 serotypes. It is effective between 9 and 16 years of age. With laboratory confirmed previous dengue infection living in endemic areas, this is a preferred one. Thank you. This is my references.
Due to lack of time, we will go to the next talk, please.
Thank you, ma'am. The next speaker is Dr. Sheela.
Hello all. Okay, I'm quickly going to rush through my slides because most of the things I have to discuss is discussed by my colleagues out there. So, all of us are family physicians here. Do we all give vaccines to our patients? Do you recommend vaccines to all your patients who ever come to the clinic? Yes, no? Raise your hands. How many of you have vaccine clinic, thought about vaccine clinic? Yes, no? Okay, start thinking about it. And do you give pediatric vaccines also? Of course, you must be, you are already seeing pregnant women. The child also should come to you. Don't you? Okay. So gone are the days we have to worry about all the endiums and the carbapenemase bugs, because we are the family physicians, we are the primary care physicians. We have to be much more ahead than the ICU personnel. So we should start giving vaccines to all our patients. Have you taken vaccines? Adult vaccines? Oh, mine. Good, Dr. Ramya, you have given this. Okay, so travel vaccine. So we see our patients or clients coming to our clinic and asking, Doctor, na urukku popore. Give me a set of medicines. It's like we have a set of prescription. Okay, print it, give it to them. Emicet, Pantocid, malaria prophylaxis, and anything to protect you from the malaria, some creams and so and so. But do we give vaccines? Tablet tavira. Vaccines eduthroma nama patients ka. So what are the vaccines you think we should be giving? Quick, 1, 2, 3, 4. Otherwise they are going to push me out of the stage. 3 of them there. So enna vaccine kudukalam? Hepatitis A, yes? Depends on where they are traveling. Super, okay, whatever, you just shoot out, whatever questions you have, whatever vaccines you would be giving. Yellow fever, okay. Yellow fever nama clinic la kudukka mudiyadha. Chennai la Port Trust Hospital la kudukranga, illati King's Institute la mattum dhaan kudukranga. It is all government dhaan kudukka mudiyum. Nama kudukka mudiyadha. We can't even buy and store in our clinic. Quick, fast. Flu shot, superb. Ellarkum varshathukku oru mura flu shot kuduthe agano. Next. I'm not going to play my slides. You are going to give me the answer. I'm going to shut it down. Hepatitis A, very good. Then, typhoid vaccine, superb. Then, varicella. Then, very good. Then, meningococcal, varicella, Tdap, hepatitis B, measles. We are seeing measles in our newspapers these days. So, okay. So we have gotten all the vaccines we need to be given. Okay. I am going to the next part now. So, doctor, pona varsham da na flu shot eduthukiten. Ipo na Australia poporen. Flu shot eduthukanuma vendama? Yes, done. Okay, no flu shot anymore. Slide kamikla. Next, sir, Tdap, tetanus la na eduthukite kedayadu. I am talking about adult case scenario here. So, tetanus vandittu na eppo potukittene theriyala. Na ipo America poporen sanna paakradhukku. TD, Tdap. our renowned pediatrician was telling us that we are the one carriers and giving to our grandchildren. Not that I don't have grandchildren now. Okay, we will be giving to our grandchildren. So, TD or TDAP? Doctor was telling that we are the ones giving it to pediatric people. Please. Should we? Should we take TDAP or give it to our patients also? Yes, TDAP. Then, so how frequently? Like at least one shot in the adulthood we need to give. At least one shot. Flu shot, every year we have to prescribe to our patients. Next, yellow fever, as doctor was telling, we need to give once in 5 years when they are traveling to that belt. It's not that all the patients need to get wherever America போறவங்களுக்கும் Africa போற எல்லாருக்குமே கொடுத்துட்டு இருக்க முடியாது ஈரான் ஈராக்லாம் போறது. So we have to see where they are traveling. My computer is sleeping. So you look into this age, sex, underlying conditions of our patient, and if they are allergic to anything or whatever medications they are already taking. இதை மட்டும் முதல்ல தெரிஞ்சுக்கணும். Next, whether they are having any special conditions, pregnancy, breastfeeding, disability, immunocompromised condition, அந்த மாதிரி ஏதாச்சும் இருக்கான்னு பார்த்துக்கணும். Then, whether they have already taken the vaccines, what all the vaccines they have already taken. So we need to know that we see lots of diabetic patients in our clinic. Diabetic patients are sweet people. The sweet people, bugs love them. Be it bacteria, virus or fungus, bugs love them. So it is the best thing that we hit them with the vaccines, whatever you have got in your hand. So this is the chart we need to be having printed in our clinic, where we say that what vaccine, when did you give, whether it is a conjugated one or an unconjugated one. Because why? Because if you write it is a conjugated vaccine, it holds good for 5 to 7 years. There is no need for him, if he is frequently traveling, to take the vaccination again and again and take the signature from us. So the cholera vaccine, as doctor was already mentioning, this is the belt which is getting affected with the cholera. So whenever our patient is traveling to this part of the African countries, we have to give them. There are different kinds of cholera vaccine available. It is an attenuated oral cholera vaccine. And the one available in India is Dicorol, Shankol and Uvicol. It is a live cholera attenuated vaccine. We need to know about it. Contraindication, if any one of the ingredients present in the vaccine, if they are very sensitive to it, we need to avoid it. Dosage, it has to be taken a single oral dose at least 10 days before travel. So when will you recommend vaccine to your patients? At least a month before travel. Or else certain vaccine like this, 10 days prior to the travel, you can recommend to them. Japanese encephalitis, to whichever map it is denoted there. Okay. We need to give the vaccine to these places. The one available in India is Genvac. It is an inactivated virocell-derived vaccine. It is safe and highly effective vaccine, protects against all the strains of JE. Dosage is 0.5 ml we need to give. Next is the rabies vaccine, already touched upon by our renowned doctor here. I am going to just quickly brush through that. So this is like, you are not going to order food now, okay? No Swiggy, Zomato. Thanks to these things, because we are seeing a big rise in typhoid happening in our community. Hope it is the same with Madurai too. So the typhoid vaccines, as our pediatrician already mentioned, there are 2 types of the vaccine available. These days we are recommending the conjugated vaccines much. But please tell your patients, none is completely effective against Salmonella typhi. Not 100%. You can't be giving the shot and you can be telling that you can go and have pani puri from a roadside eatery. and none provides protection against paratyphoid, which is in the surge these days. It is not only the typhoid, paratyphoid we are seeing. And none is protective against the drug-resistant strain of Salmonella typhi. These three things you have to mention to your patients whenever you are giving typhoid vaccine to your patient. The meningococcal vaccine, which is very prevalent in this belt. And this is the ACWY vaccine is available there. It has to be given 2 doses, 2 months apart. Again, 1 month prior to the travel or 6 months prior to the travel, you need to finish both the 2 doses. Yellow fever vaccine, it is prevalent in these belt, and it might cause certain neurological side effects like this. Dosage is 0.5 subcutaneous. We won't be giving it. The government gives that. So the routine immunizations, as we already discussed, the SARS-CoV, the influenza, Tdap, measles, mumps, rubella, at least 1 dose he should have taken, not in the pregnant woman. We should be aware that certain live vaccines we can't be giving to the immunocompromised patients or the pregnant women. The polio, the injectable polio vaccine, especially our community who goes to the Hajj, we have to give them. And varicella is definitely recommend to all your diabetic patients 2 doses, and hepatitis A and hepatitis B too. Thank you so much.
Thank you,
And
Dr. Sheela.
Yep.
Very nice. We traveled through all the immunizations very rapid phase.
Thank you so
Now
much.
we are waiting for the inaugural program where the minister has arrived. So kindly bear with us. Let us have the inaugural function, then we'll continue again with the CME program. Thank you.